Hey everybody, how's everyone doing today? Trying to get this lighting here. I know it's difficult, but hey, I want to address with you today. I've received a couple of emails the last couple of weeks, both from the Spirit Care Association and APC, stating or referencing a study on um, how healthcare chaplains don't know their role and function. The vast majority of them don't know exactly where they fit, and they can't articulate their role and function. Well, I like to speak to that because I certainly don't have that problem, because I know why I'm doing what I'm doing. And what helped me to understand that is, look, generally, if most of you are working in general hospitals that are not, and if you're not working in a psychiatric hospital or a mental institution or anything, you must first understand some things. So it will help you understand your role and function in a hospital. Now, you must ask this question: what is the task of the hospital? The task of the hospital in general is to bring in or input sick people, and their goal is to output healthy people, or getting them on their way to make them more healthy from sick to health. That is their primary role. And sometimes, obviously, the caring for those who are near the end of life, but that's really a little different story, or a different thing that is to be addressed somewhere else. Now, who are we as clinical chaplains? We have a religious, in theory, a religious background, um, and we're kind of operating as counselors. So the other thing is that we must answer or come to understand, or some basic assumptions, that the hospital is not a counseling center where people are coming for emotional and psychological help. That's not why they're coming to your hospital. They're coming to resolve their physical ailments. Get that clear. Number two, it is not a church. Yet, strangely, that's what a chaplain in a traditional sense. I know there's now atheist chaplains coming on board, and all different types of chaplains that's representing different religious faiths. So the very thing that the hospital is not is what we are there. So you really need to ask yourself, what is our role within that? And until you come to the conclusions that that until you really understand the role of the hospital, and then you must ask the question, as the competencies that I have, how do I fit within that? How do I fit within getting sick people in, and discharging and outputting healthy people? What is my role within that? Until you really come to terms with that, you're really going to be just this shotgun effect in your hospital. You're just visiting patients randomly. You're just visiting patients, for coping and comfort. Well, volunteers can do that. Dogs can do that. The 80-year-old volunteer grandma can come and do that, and you don't need to pay anybody for that. So many of you, until you really need to come to terms of what you're doing. And so, it goes back to why we exist. Anton Boysen was training the clergy. The context initially was in mental facilities, helping people get better. There was a focus. It's a mental institution. It was getting people mentally sick better. So it was relevant there. So what is your role in a general hospital? Just for comfort and coping? Oh my goodness. Um, Everyone in the hospital that delivers care, in theory, is to provide comfort and coping. Anton Boysen himself says, in his book Exploration of the Inner World, which probably many of you have not read any of his literature, have you? None of your CPE training is bringing in this Anton Boysen. None of his literature are they? Uh-uh. Um, he says, comfort and coping, it will always be part of my job, but in paraphrasing, yeah, I have better things to do. In the hospital, I have people with a crisis in their lives who are mental breakdowns, and I'm here to help them. So the purpose of the mental institution is to input mentally sick people and output healthier, mentally healthier people, right? So again, what is your role in the general hospital? It's clear to me, and I'd like to share it with you. Irvin Yalom, in his first, I think it's the first chapter of his book, The Gift of Therapy, says basically what he does, again, in counseling, is to help psychologically, people who just need help psychologically, just to get things back right, their interpersonal relationships, or, mental disorders, or just, to get them to get emotional health. And so what he says is, I just remove obstacles. My job is to remove obstacles for people to get more mentally health. So again, he has a clear focus and a clear outcome to hope for. But again, what is yours in the hospital? Mine is, and is very clear, that I have developed in my hospital. I remove obstacles to care. The obstacles to care are indicators that are telling me, or they are identifying the most distressed patients in the hospital. The people that have barriers to the care definitely have issues going on. They're the ones who are suffering the most. Suffering so bad that they are refusing interventions that they're to get them healthier, physically healthier. So my role in my general hospital, one, primarily, is to identify those patients who are so distressed that it's impacting their care. Now, remember, that's what the hospital's there for, is to get people out healthier, healthcare outcomes. That's where I fit, right? And so, and so these are barriers to care. Those who are refusing care, who are having a hard time making a difficult medical decision. So these are the most suffering people. And because most of these problems, they're actually psychological and spiritual in nature. I can give you examples of how I was able, and when I say spiritual, see, many of you think spiritual, you think of God right away. To me, spiritual is the human being. I care for the human spirit. And in that, religion and God does come into play. Actually, religion comes into play. Unhealthy religious theology or views actually impacts care as well. So, and it can interrupt quality care. So that's where a chaplain come in. We have two hats. Well, if properly trained, a psychological and a religious hat. We can take them on and off to provide that care. And so we can go into that room and help identify and help people process those barriers and to reduce the distress to at least relative stress so that they can get the care that they need. And then we move on. This idea that, you know, I don't, for any viewers or watchers who think, well, the research this, research that. Now, I've read a whole lot. If we meet their spiritual needs, they have these health outcomes. In my case, yes, removing barriers, but there's research saying that if you do this, they have these long-term effects. Come on, man. Those psychosomatic things take a long-term therapy. It's long-term therapy that's going to help patients in the long run through that chronic stress of their life, that chronic abuse, that chronic stress in the life that's brought on this on-site illnesses in them. That's not going to go away with you in one visit. The patient is there is 2.5 days. And depending on your hospital and your resources, come on, man, you're going to get it once. But a well-trained chaplain, clinical chaplain, being trained from a psychodynamic point of view, helping understanding human behavior, understanding personality disorders, defense mechanisms, human development, because how someone comes into the hospital, whatever distress they're going in, they have their whole life, their personality, whether it's dysfunctional or not, they're using their dysfunctions, potentially dysfunctions, to deal with their distress. And if you don't know what you're looking at as a chaplain, because look, I sit on boards, I sit on the APC boards, and I'm telling you 95% of the time, none of the chaplains know how to listen. They're always talking about God, trying to force prayer down their throats, saying, well, how's your relationship with God? Come on, man. You can't. You need to start moving away from this quantitative approach to care with these chaplains. You need to sit down and listen to the patients who are in distress, help identify what is keeping them from moving forward in their care. But it takes a well-trained, competent chaplain. But the CPE training that most are getting right now, it's about as good. It's a high-grade volunteer. You passively listen. You don't know what you're listening for. You don't know what you're listening at, generally. In the last 2 years, I've sit on APC boards. There's not, when people are writing their theologies or theories of pastoral care and their approach, I can almost literally, I have not read the word listen. But when I see listen, I don't say listen passively, but listen actively. It is amazing what, I don't know, you don't want to point to the supervisors, or I'm sorry, educators directly, because a lot of development is based on the person who wants to develop. But I just don't get it. So let me just get back again to why I'm even doing this. I believe that my role and function is clear and it's effective. The chaplains that work for me now have meaning and purpose in the work that they do. They know what's expected of them. and they have actually goals. It's just not passive listening, passive work that we're just walking around um, helping people cope and comfort. That is so elementary. The work that you do, the higher level of work, the byproduct should be comfort and coping, not the primary reason why you're there. So, um, until we get this idea that, uh, or because oftentimes we don't know our value, people don't value us. That's because you're not doing anything. You're not doing thing of value. We're just a bunch of nice people walking around the hospital. Occasionally walks in and the nurse says, "Oh, thank you for coming by," because they were so sad. The nurses don't know that that we can go in and help them in that patient's plan of care. We can help that nurse when a patient is refusing care, not doesn't want to do a procedure, not taking their meds, or excessively using their call button. They don't know that the use of our clinical competencies can help process. But most of us don't know what we're processing. Help that patient process, help them identify and be heard and understood and being attuned to the patient. Um, and all these therapeutic interventions can help. One, that's real staff care, not walking around patting them on the back and saying, "Hey, how you doing? I really care for you." But real staff care is concrete staff care, is making their life easier on a day to day. That's concrete staff care. And so, um, and yes, uh, there is a role that we have, especially what I would call, a tier two, those who may not have barriers to plan of care, but existential crises. They've just been told that they have stage 4 cancer, or cancer is a new diagnosis. We're there here to help to process them. Yeah. And I think that's vital in a hospital. I think that the healthcare industry has forgotten um, that they're responsible not just caring for the body, but caring for the soul. Right. So I believe that a clinical chaplain should be in hospitals. We should be caring for the soul as much as the body. So we do have a rightful place in the hospital. Um, we often are probably better than I won't say better than a psychologist, but we have that religious background. We have that religious language where in moments of crisis that pops up, right? So we can wear these both hats. So the clinical chaplain, we're primary counselors. And I wish, this is another topic for another day, and that we move away from this MDiv requirement for certification. We need counseling degrees, not MDivs. We need pastoral counseling degrees that is mostly about counseling and some religious aspect to that. That's who we are. We're here to de-stress institutions so they can provide the interventions so patients can have good health outcomes. This is a clear role distinction, a clear function, and clear value that we bring to the hospital. We contribute to health outcomes. We contribute to health care, which is metrics, measurements, and finances. And we contribute to healthcare providers, i.e. staff care. I could do all that in one visit. And until we have I have a crystal clear um, that we just need to understand that we need to speak the hospital language and quit asking the hospital to come to us and to understand us and to value us. Until you are of value, until you change, you're always going to feel this way. So click on subscribe, like, share this video. I would like to continue to start talking more about topics to help clinical chaplaincy, because where we're going and what we're doing and the research, I think, is in the wrong direction. So they can just, well, I won't go there. So even if you comment, maybe there's some other topics that you would like to discuss. Again, subscribe, like, and share this video. Take care and do chaplaincy well.